Assalamu alaikum. The long clinical consultation day. First scenario, Mrs. Sarah, 36 years old, with complaint of dysphagia. You are the doctor in the clinic. Please examine and take history and address her concern. Ready, Dr. Mahmoud?
Yes, ready. Yes, ready, Dr. Basim.
Okay, here you go.
With timer. Okay. Okay, good evening. I'm Dr. Musa, doctor in the clinic today. Let me confirm you are Mrs. Sarah, 35 years old.
Yes, doctor.
Yes, Ms. Sarah, we are here to discuss about your recent complaint and also to examine you. Is it okay with you?
Yes, okay, doctor.
Okay, brought to my knowledge, Ms. Sarah, that you have difficulty for swallowing. So could you tell me more about that, please?
Yes, doctor, I have this difficulty of swallowing. I noticed that like 6 months back, and it was not bad. Then I noticed it's increasing, so it's now bothering me. That's why I came to you.
I'm sorry for that, Ms. Sarah. I hope to help you. It is the first time you have this difficult swallowing or any previous attack?
Yes, this is the first time.
It is worsening since 6 weeks. Since
Yeah,
6
it's
months,
increasing.
sorry.
6 months, yeah.
Okay, sorry for that, Ms. Sarah. Ms. Sarah, do you notice that anything increases difficulty swallowing, like any exertion or any specific type of food?
No, doctor.
Do you notice that it is more to the food, solid, or to the fluid?
Actually, doctor, I noticed that it's more to the solid
Solid.
food.
Okay. Do you notice anything that Ms. Sarah help you about this difficult swallowing, like drinking water or any specific butcher?
No, doctor, but I'm trying to chew the food as much as I can, and I try to make my food like soft. Yeah.
Okay. Okay, Ms. Sarah, do you have any during taking food any pain?
No, doctor.
Can you describe to me? Can you show me where the food is stuck exactly? It is in the upper air pipe, food pipe, or in the middle or the lower?
Yeah, doctor, I think it's in the upper side, yeah.
In the upper side, okay.
Mm.
Sarah, do you have any mouth sores?
No, doctor.
Do you have any tongue pain?
No,
Any tummy swelling?
no,
Any change in your bowel, like loose motion or hard motion?
no,
Okay. Do you have any joint pain?
no, doctor.
Any back pain?
No,
Any specific any rash in your body?
no,
Okay. Do you have any rise body temperature?
no,
Do you feel tired?
no,
Any tiredness? No. Okay. Anyone notice that you are pale than before?
no, doctor. No.
Any weather preference? You prefer hot weather or cold weather?
Yeah, actually, doctor, I feel I cannot tolerate the hot.
Since when it start?
I think it's long time, maybe 1 year.
Any weight changes recently?
Yeah, I'm losing weight, yeah.
How much and for how long?
I think I lost like 5 kg over 1 year, 5 or 6 kilograms, yeah.
So, sorry, how much?
5 to 6 kilograms.
Okay. What about your appetite? Is normal or low for appetite?
No, it's okay.
Do you have any lumps or bumps in your body?
No, doctor.
Okay. Do you have any weakness in your body, Ms. Sarah?
No,
Any numbness or tingling?
no,
Any history of loss of balance?
no.
Any racing heart? Do you have any racing heart?
Yeah, sometimes, yeah.
How frequent per day or per week?
Actually, I don't notice, but sometimes I feel like my heart racing, yeah.
It is regular or like my tap or irregular?
Yeah, I think it's regular, yeah.
It's regular. Do you have any chest pain?
No, doctor, no.
Any lower limb weakness? Any lower limb swelling?
No,
Okay. Do you have any cough?
no,
Any shortness of breath?
no,
Do you have any shortness of breath? Okay. What about your water work? It is regular? Any change in
Yes.
the amount or frequency?
No.
Okay. Okay, Mr. I will ask you some general question. Do you have any hand shaking?
Yeah, sometimes, yeah.
Do you have any hand sweating?
Yeah, maybe yes.
Can I ask you a private question if you don't mind?
Okay.
Okay. Are you married?
Yes, doctor.
Do you have children?
Yeah,
When was the last child?
was like 3 years back, doctor.
What about your period? It is regular or
Yeah, it's okay.
it's okay? Okay.
Mm.
Do you use any pills?
Yes.
Okay. Do you travel any history of travel recently?
No, doctor.
Okay. I will ask you a private question if you don't mind. Do you have any history of blood transfusion?
No.
Any sharing needle, tattoo, piercing?
No.
Okay. Do you have any long-standing disease should be aware?
No.
Any previous infection or previous admission in the hospital?
No, doctor, no.
Can you give me your medication list, please?
No, I'm not taking any medication, doctor. Only my
Uh,
pills.
Sorry? Pills, yes. Okay.
Only my pills, yeah.
Okay. Do you take any illicit drugs or party drugs?
No.
Okay. Do you have any family history of any gland disease?
No, doctor, no.
Okay. Okay. There is picture?
No, but no specific facial features. No.
No specific, no neck swelling, no.
There is neck swelling, yes.
There is neck swelling.
Yeah,
Okay.
but no facial features.
Okay. Ms. Sarah, do you have any visual problem?
No.
Any visual blurring or no vision problem? Okay. Can I
Yeah.
do? Okay. Can I know what do you do for living?
I'm accountant, doctor.
How much is symptoms impacting you in your job and daily activity?
Yeah, only it's worrying me, doctor. What's the cause of such condition? Yeah.
I'm sorry for that, Ms. Sarah. I hope to help you and give you suitable treatment. Do you smoke, Ms. Sarah?
Yes, doctor.
Okay, I advise you to stop smoking. Do you drink alcohol?
No, doctor.
Okay. Okay. Let me examine you. First,
Okay.
I want to look the patient if there is any proptosis or exophthalmos.
No.
No, there is only neck swelling.
But yeah. But the examination, you will start by looking to the.
I want to look to my patient.
Okay. So
Okay.
how you know there is proptosis or exophthalmos?
Okay. I will start by the hand to see if there is any liponychia or chronicia or thyroid acropathy in the nail.
No.
No, okay, then I will ask Ms. Sarah to outstretch of her hands if there is
Yeah,
any and also
has.
if there is
Yeah.
any tremors, any shaking
Yeah,
of
she
the
has
hand.
fine tremors, yes.
She has fine tremor. Okay, then I will go to the pulse to examine if there is any tachycardia or AF.
Yeah. The pulse 100 beat per minute, regular.
Okay, then I will go to the blood pressure and also blood pressure and if there is any collapsing pulse.
Okay. There is
If
collapsing pulse.
there is collapsing pulse, okay, then I will do for proximal myopathy.
Okay.
It is
There is
positive,
proximal myopathy.
positive, I think, yes. Then I will go to the eye. I will stand, I will see first visual acuity, then each visual acuity in the front.
How we will see the visual acuity?
Yes, I will stand from 2 meters or 3 meters to see if there is any problem in the visual acuity.
How we will
Yes, but this is how I will. There's 3 fingers. Do you see
finger
this?
counting? Okay.
Yes, finger counting. Yes.
Okay.
Okay.
It's normal.
Okay. Then I will يعني behind sit beside Miss Sarah to see if there is any exophthalmos or any proptosis. Exophthalmos that I will see the eye white above the cornea. Yes. Exophthalmos
Yes.
and the proptosis.
Yeah.
There is positive.
Oh, negative.
Negative.
Yeah.
Okay. Okay. Then I will do negative. Okay. Then I will do lid retraction also by my finger in front of her hand, and also raise my finger as C.
Front of hair.
Yes, from the eye to like C, inverted C.
Okay.
No. Yes.
No lid lag.
No need like okay. Okay. Then I will do H shaped. I will move my finger as H from the center to the periphery to the and ask Miss Sarah if you see any double vision or pain. Let me know if there is any ophthalmoplegia.
No double vision, no eye.
No double vision. Okay. Then I will
No
do.
pain, sorry.
Okay. Then I will stand beside here and give her water and ask her to drink while I drink and see if there is any this moves with swallowing or not.
Yes, there is a
Okay.
mess, moves or swallowing. Yeah.
Also swallowing. Okay. Then I
Yeah.
will go to from behind here to palpate the swelling. Is it is diffuse or in nodules?
How you palpate? Behind here?
Yes, behind the hair. Yes.
Yeah.
And my
Okay.
finger and my
Yeah.
finger in here. Okay.
Yes,
The
yeah. There is nodules here.
nodules.
Mm.
Okay. Okay. Then I will the palpate and then I will auscultate if there is any bruit.
Yeah, no
And
problem.
okay. Then I will go to the heart to listen if there is any murmur. Listen if there is any murmur in the heart.
No murmur.
Okay. Then I will no murmur. Then I will go to the lower the lower limb to see if there is any rash in the
What
lower
rash?
limb. I don't remember. If there is any rash in
Okay.
the lower limb,
No rash.
no rash. Okay. If there is any lower limb edema,
No edema.
okay. Okay, Mrs. Sarah, can I know what's your concern, please?
Yes, doctor, what's this cause of my difficulty of swallowing?
I do understand your concern, Mrs. Sarah. I think there is a growth in the gland, which is located in front of your neck. It's called thyroid gland, which produce some protein called thyroxine. It causes your symptoms, and also this overgrowth of the gland compress on the airway. Sorry, compress on the foodway.
2 minutes left.
That's why you have difficulty with swallowing.
So, doctor, it's curable condition, doctor?
Yes, Ms. Sarah. I will refer you. I will refer you to endocrine, so to gland doctor to give you proper plan. The plan will be maybe surgery or give you some medication. But let me ask you, Ms. Sarah, do you have any dizzy spells when standing from sitting position?
No, doctor.
Okay, Ms. Sarah. Okay,
So,
do you
doctor,
have?
yeah, I'm planning for pregnancy, doctor. Yeah, this can be with this condition, or I cannot.
If you want to get planned, it should be planned pregnancy. I will refer you to the woman doctor to give you proper plan.
Okay, doctor.
Okay. Okay. Blood pressure normal. Sorry.
Yeah.
Mhm. Okay. Do you have any other concern, Ms. Sarah?
No, doctor. Thank you.
Mhm.
Okay, 20 seconds. You want to ask anything else or to examine?
Yes, I think there is thyroid.
6, 5, 4.
Okay. Okay. Any change in the water work, passing any gravels or stone?
No, doctor. No.
Okay, time is up. The examiner questions.
Okay. Can you present your case?
Yes, today I examined Ms. Sarah, 35 years old, who's complaining of difficulty of swallowing. It started since 6 months, more to the fluid. During history with Ms. Sarah, there is
More to the fluids?
more to the solid.
Mm.
Yes.
Mm.
Okay, she can tolerate hot weather. Besides that, she lose weight over this period. Also, they have hyperthyroid status in the form of hand sweating and head shaking and racing and tachycardia. Also, she have neck swelling. During examination. I couldn't appreciate any Graves' eye disease, but during palpation there is multinodular nodules in the thyroid.
What's your differential?
So my first diagnosis will be multinodular goiter. Multinodular goiter. And second official diagnosis will be Graves, maybe Graves with neck swelling and in the early stage. Maybe also cancer, thyroid cancer. May also be thyroid abscess or thyroid cyst.
Yeah. So how you know it's thyroglossal cyst, you mean? Huh?
Sorry?
Thyroglossal cyst, you mean?
Yes, thyroid cyst.
Yeah, how you know it's thyroglossal cyst or
Cyst
thyroid?
or
How you know it's thyroglossal cyst or thyroid enlargement, thyroid mass?
I don't know.
Okay.
Advanced question.
Okay. So how you investigate this patient?
Yes, first I will admit Mrs. Sarah, and I will do basic blood test, CBC, looking for any anemia or any increased white blood cells, looking for any infection. Also, I would like to do liver function test and kidney function test and inflammatory marker, CRP and ESR. Then I will do thyroid antibody, anti-TSH receptor antibody, searching for Graves. And also I will do TSH and T3 and T4. And thyroid ultrasound. And maybe need fine needle aspiration cytology to know it is hot nodule or cold nodule.
How you know it's hot nodule or cold nodule?
According to fine needle aspiration cytology. If it is the cold nodule, it will be the difference here will be a need for surgery because it might be malignant. But if it is hot nodule, I will do first medical treatment.
Okay.
Okay.
Okay. The treatment?
Yes, treatment after admission of Mrs. Sarah and doing a blood test. I will do non-pharmacological patient education and counsel about her condition, and also advise her about the compression signs of goiter. And if she has any shortness of breath, she should report it to me. And then then medical by multidisciplinary team of endocrine endocrine surgery and endocrine surgery to give him proper plan. The plan will be by maybe medical, by giving here anti-thyroid medication like carbimazole or propylthiouracil, and also surgical. It is an option, and may need radio frequency.
What's the indication of surgery?
Yes, surgery if there is any compression signs, like Miss Sarah have, it is dysphagia. If she has compression, and also second, if she has still have symptoms despite treatment, and yes, and if a patient need to go to need to be pregnant, and prefer yes, and prefer that, and for maybe cosmetic as patient preference. And if
What are the medical treatment options you mentioned?
yes, medical treatment, it will be by medication like carbimazole or propylthiouracil. But first choice will be carbimazole. But if she needs to be pregnant, we should change the carbimazole to propylthiouracil.
Okay.
Any question, Dr. Ala?
Okay, thank you.
Mhm.
Okay, I will add one question. What
Yes.
are the compression signs, or
Yes,
compression
compression.
symptoms?
Yes, compression signs, difficulty of swallowing or difficulty of breathing, or any change in the voice, like hoarseness of the voice.
Okay. Is it indication for surgery?
Yes, it is the first indication for surgery, I think.
Okay, what are, in this patient,
Mhm.
in this patient particularly, you didn't mention iodine as radioactive iodine as management. You mentioned as an option?
Yes, after the surgery, radioiodine uptake, option treatment or option investigation?
No, as a treatment. For the investigation uptake.
Uptake, yes.
Yeah, here as a treatment.
Radioiodine frequency. I think
Okay. You mentioned, okay. Is it accepted in this patient? Would you prefer to give her or to start her on radioactive iodine?
Yes, according to this multinodular goiter, preferred
No,
radioiodine.
I'm talking about the history part. This patient at the
Yes,
end give you a
the-
concern.
Yes, in the history part, patient has compression symptoms, so the first option would be surgery.
Okay. If she want to be pregnant, is
Mhm.
it wise to start her on radioactive iodine?
No, it should be, I advise here to not be pregnant before 4 months.
Or only?
4 months? 4
I
months.
think longer. I'm not sure about the duration. Anyway, what are the contraindication of radioactive iodine? Last question. Our case today?
Radioactive iodine, I don't know.
Yes. If planned for pregnancy,
Yes.
or what other contraindication of radioactive iodine?
Graves, no? Graves, yes,
Yes,
Graves,
yes,
Graves,
yes,
Graves
eye
eye
disease.
disease. Yes.
Yes. Okay, and children.
Children, yes.
Yes, if this patient either pregnancy or planning for pregnancy or children around, and the last is eye disease. Okay, that's enough. Thank you, Dr. Mahmoud. Well
Thank you,
done.
Dr. Bas.
Dr. Ala now will comment.
Yeah, very well done, Dr. Mahmoud. You did a good approach for the dysphagia. Okay. Actually, this is like the common case that anyone can face in the exam. That's why I brought like not to only diagnose the case or to know what she had. No, only for the approach, how to do the proper approach, either taking the history, making the differential, addressing the concern, and also examining the patient. Actually, Dr. Mahmoud did all enough. Okay, fair enough. Only the thing that he didn't do the percussion for the retrosternal extension in the examination and the tongue protrusion to differentiate between the thyroglossal cyst and the thyroid mass. Otherwise, he did all the required examination and also he did good history also. That's it. Yeah.
Yes, well done. Thank you, Dr. Ala, for the case. I agree for the comment. Only the retrosternal percussion he missed. And I think he examined for the Berwi, right? He auscultate. But the retrosternal he missed. Okay. Based on the case now, I will ask Dr. Mahmoud, what are the differential diagnoses for this case as thyroid swelling?
Yes, thyroid swelling, patient first multimodal goiter, and the second maybe Graves disease, and
Okay.
third, but apart from that, no eye signs, and also maybe subacute thyroiditis. But I ask about any previous infection or no fever.
Yeah, so against that, you can mention.
Yes.
And what else in the females?
Um,
You mentioned Graves.
I think he asked also, he asked in the history.
About?
The last delivery, you asked about the last delivery, Dr.
Yeah,
Mahmoud.
yeah, that's why. Females. Dr. Mahmoud.
yes,
What
doctor.
are the most
Yes,
common cause of
in the
hyperthyroidism?
most
Or
common cause,
goiter?
goiter Graves.
Graves. Okay, you mentioned Graves. What
Yes.
else?
Yes, if you mean Dr. Bassem, if she has
The causes, yes, or the causes.
yes,
Okay. Tell me the cause of hyperthyroidism.
yes, maybe Graves,
Okay.
multiple goiter and
Dickervan, subacute.
Dickervan,
Yes,
subacute.
okay.
Yes, and maybe you mean postpartum thyroiditis.
Exactly.
Yes,
And yes, I know, but you didn't mention by name. Okay, what more? One more.
postpartum and yes, thyroid cancer.
No, thyroid cancer always as cold. It will not be
Yes.
an active or. Okay, one more.
One more.
Okay, two more.
Okay.
Yes, two more. There is one more for the female. Hashimoto.
Yes, Hashimoto. Yes,
And
Dr. Bass.
hyper, because always the disease, thyroid disease comes either AO or, as you know, hypo or hyper. Sometimes in Hashimoto, as a hyper state, you can mention as a differential or as a cause. The last one, external, right? Patient taking thyroxine.
Factitious thyroiditis.
Yes, most of the females as losing weight.
To losing weight.
Yeah,
Yes.
exactly.
Yes, Dr. Bass.
We are using it. Okay, that's enough for the questions. Otherwise, the performance perfect. You finish the history as soon as possible. Why? Because you have a lot to examine. You examine the peripheral signs, tremors and sweating, proximal myopathy. You examine the eye symptoms. The eye signs. You examine also, and manifestation, and the thyroid itself. Don't forget to ask the patient to get her tongue out. It's very important to rule out thyroglossal cyst. And the last examination for the thyroid itself, lymph node. I don't think you examine the lymph node.
No,
It's
I forgot.
important.
I
Yeah,
forget.
always offer the lymph node examination. If you will not
Yes.
have time, offer it. But you should do. Okay. Although it's not common to have thyroid cancer with activity, but still you have to do lymph node examination. Okay.
Okay, Dr. Bass.
Okay, thank you, Dr. Mahmoud and Dr. Ala. Any
Thanks.
comment about this case for anyone? Let's read the differential, and during that time, Dr. Mahmoud, please write your case for Dr. Ala.
Yes.
Okay, I will write. I will read the comment. No one wrote thyroid as a differential initially, but it's okay. It's not necessary to be the case from the initial and differential. At least you have to know the differential at the end of your case. Be ready and be fast as much as you can to write differential according to the finding. Even you didn't write it earlier, you have to change your differential according to the scenario. Of course, it's difficult to guess that the thyroid is one of the dysphagia cause in this scenario. However, if you write it, it's good. If not, you can change it quickly, and you can write the causes of hyperthyroidism or the goiter itself, not only the the goiter. Okay, so you change the differential totally to the goiter causes. Or if he asks you what the causes of dysphagia, as Dr. Mahmoud did in the analysis of the complaint, you have to know at what level you are talking about dysphagia. Is it at the mouth level, or at the neck, or at the chest? Simply. So you'll ask the patient, as he did, where exactly you feel difficulty of swallowing. You can add for myasthenia gravis, you can add, do you think the food particle comes from your nose? If you suspect it. Okay, otherwise, the localization of the area of difficult swallowing will guide you to the cases or to the differential. In the chest, you can find a lot of them like achalasia, GERD, or even the systemic sclerosis or esophageal cancer. The other question you have to ask for the analysis, is it initially for the solid or the liquid? And again, according to them, you will find your differential. If he said, for example, it started to the fluid, then later on becomes to the solid, what will be the case? This is a question. Who can give me a differential? If he said, or the patient said, I have difficulty of swallowing to the to started to the liquid, then change to the solid.
Yes, it is functional, Dr. Basim, maybe neurological, motor neuron disease, or multiple sclerosis, or maybe achalasia, or esophageal dysmotility syndrome,
Or the most important one,
myasthenia gravis.
no, myasthenia gravis will be at a higher level, not at the chest.
Um,
I'm talking about the chest level. It started to the fluid, then with the time it become to the solid as well. I think
esophageal spasm?
cancer, no, cancer is on the top.
Cancer.
Yes, cancer.
Yes.
Okay. For the achalasia, it would be against the fluid as well, and you will have fluid level, as you know, but the solid will be easy to pass. Okay. Again, the clue of dysphagia in any scenario, or the hint, you can get it from the level, and according to the level you can have a lot of differential. For example, in the mouth part, if we have a case of difficult swallowing in the mouth, he cannot swallow from the start, what do you think the differential will be? I mentioned the myasthenia because this is the most important you have to roll.
Yes, from start, odynophagia.
This is with pain. The
Yes,
good
with
question
pain.
also, yes, you ask about, do you have any pain while swallowing? This one will guide you to another differential. So there are a lot of questions you have to ask. One of them, the pain. But let's finish the level first, okay? In
Yes.
summary, at the mouth, what do you think the cause of the difficult swallowing at the level of the mouth?
Yes, Sjogren syndrome. Sjogren,
Sjogren, dryness,
dry,
yes.
d-
Yes, exactly,
dryness.
yes. Due
Yes,
to the
and
dryness, yes. And
yes, candidiasis painful.
perfect candidiasis will be with pain, but still in the
Well,
mouth part. So any
yes.
mouth ulcer or any candidiasis can be a cause of dysphagia at the level of the mouth. And on the top of them, myasthenia gravis. Okay?
Mhm. Yes.
At the level of the neck, as our case today, thyroid on the top and bulbar, any bulbar stroke, right?
Yes.
Motor neuron, any neurological cause. Patient will cannot swallow because of initiation or not initiation, the initiation at the mouth. Now we are talking about in the swallowing itself. So either neurological, as in this scenario, It was sorry. In our scenario, was thyroid or neurological. So you can put motor neuron or our patient today or Parkinson. Any neurological cause, you can put it as the second differential in the esophagus. The third differential in the neck could be what else in the neck can be a cause? The pouch, right?
Yes.
Esophageal thyroglosal cyst, any anatomical part. Okay, then at the level of the chest, here you can put, again, as I mentioned earlier, systemic sclerosis or motility dysfunction or GERD, achalasia, or cancer esophagus. Okay, clear now for all? This is the approach of, or how to, in summary, how to approach for dysphagia. And the differential, of course, according to the level. Don't forget to put according to your level. You can ask the pain, as I mentioned, the causes of dysphagia, odynophagia. It's called odynophagia. So dysphagia with pain. The first, mouth ulcer, dryness, or candidiasis, or
Moniliasis.
what? Sorry.
Moniliasis from methotrexate.
Okay, mouth sores. You mean any mouth sores cause? Okay. Any mouth ulcers. I mean. What do you want to say?
Painful dysphagia, maybe also esophageal ulcer from non-steroidal.
Okay. You mean from not non-steroidal, but bisphosphonate.
Bisphosphonate, yes.
Yeah, but it will be painful at the level of the chest, esophagus level. Okay. Any question, Dr. Mahmoud and Dr. Ala?
Thank you, Dr. Bass.
Okay, let's.
Thank you, Dr. Bassem. Thank you.
Yes, most welcome. Number 18, yes, you can put it as a yes, as a neurological again. It's one of the neurological cause. TSN, Dr. Sarah, what the TSN? TSN, you cannot.
Positive
TMN.
solitary nodule, I mean, for differential side.
Okay, yeah. You put the differential for the thyroid itself. Okay. We
Yes,
need to examine the abdomen.
when you
and-
are mentioned.
Okay. One more question. How to differentiate between the type of goiter? Is it Graves? Is it multinodular? Is it toxic nodule? How to differentiate?
Radioiodine isotope scan. Radioisotope
Yes.
scan.
Exactly, yes. Okay, Dr. Ala, your case.
Yes, and that's also the question for Dr. Mahmoud, how to know it's hot nodule or cold
Yes,
nodule.
exactly. This is the same
Yeah.
question.
Yeah, he said by the fine needle, but the fine needle we are doing after confirming this is hot nodule or cold nodule by the uptake scan.
Uptake
Yes.
scan.
By the way, fine needles mean histopathology. You are doing for the histopathology classification, okay? Not for the activity. Activity will be by radioactive iodine or iodine uptake, sorry. Iodine uptake. Okay, Dr. Ala, your patient is Mr. Sami, 45 years with complaint of chest pain.
Okay. Hello, I'm Dr. Mitwalli. I'm the doctor in the medical
Wait.
outpatient.
Wait a time, yes. Okay.
طيب, listen.
Yes. Okay, sorry, Dr. Ala. Before you start, also, I need from all candidates and doctors to write, as previous case, a differential diagnosis from the start initially and change it according to the finding later on. Please, Dr. Ala, don't look at the chat box. You can start now.
Okay. Okay. Hello, I'm Dr. Mitwalli. I'm the medical doctor in the outpatient clinic. Let me confirm you are Mr. Sami, 45 years old.
Yes, doctor. How are you? Yes.
Yeah, Mr. Sami, I'm here to discuss with you your health condition and to examine you. Is that okay with you?
Okay, doctor. Thank you very much.
Okay. It came to my knowledge that you have been troubled with chest pain. Can you tell me more about it?
Yes, doctor. I've been complaining from chest pain since 3 days. I can't tolerate, doctor, the chest pain. So I come
Yeah, I'm sorry.
today to find the causes. Thank you, doctor.
Yeah, I'm sorry for this, Mr. Sami. So it started only 3 days ago?
Yes, doctor. I think it is 3 days ago. Yes.
Yeah. Okay. Do you have any chest pain like this before?
Yes, doctor. I have many chest pain before, but it is the most severe one.
Okay. And this pain is similar to the pain you had before, or it's different?
I don't know, the doctor. I think it's the same, but more severe.
Okay. Can you tell me where exactly in your chest you feel the pain?
Yes, doctor. It is in the middle of the chest and also to the
Okay.
left side.
Okay. So can you tell me the nature of this pain? It's like sharp pain or compression or dull?
No, doctor. It is not dull or sharp pain.
It's like heavy or compression,
No, doctor.
compressing?
I can't describe it, but I think it is like burning. I think is that.
Okay.
Sometimes it's dull aching. Sometimes heavy.
Yes, okay. If we to check severity of this pain, to give it score from 1 to 10, 1 is the minimum and 10 is the maximum, how much you grade this pain?
Yes, doctor. I think it is around 4 to 5.
Okay. Do you think this pain is moving to another parts of your body, like your shoulder or jaw?
No, I don't think so, doctor.
Okay. Do you have any difficulty of breathing?
No, doctor.
Do you have any leg swelling?
No, doctor. But as you
Oh,
see, doctor, I am overweight.
okay. Did you gain weight, you mean, or this is your baseline?
No, doctor, I have gained weight since a long time because I didn't do any exercise. I sit in the home all the time.
Yeah. And how much weight you have gained over the last period?
No, doctor, I don't need to eat. I am overweight by the nature.
Okay, you didn't gain weight.
No,
Okay.
but my weight is over.
Yes, okay. Do you have any leg swelling?
No, I don't think so, doctor.
Do you have any cough?
Cough? No, doctor. No.
Okay. Do you have any high temperature?
High blood temperature? No.
Okay. Uh, do you have any tiredness?
No, doctor. No.
Did you notice any lumps or bumps in your body?
No, doctor. I don't think. No.
Okay. Do you have any headache?
Headache? No.
Do you have any weakness in any part of your body?
No.
Okay. Did you notice any shakiness of your hand?
No.
Did you notice any problem in your vision?
Vision? No.
Do you have any tummy pain?
Tummy pain? Sometimes, doctor. Yes.
Yeah, where is exactly?
Yes, I think it is the upper tummy.
Since when this started?
I think since 1 month, I think, doctor. But
Okay.
it increasing more.
Yeah, I appreciate this. And this pain, it's like, can you tell me the nature? It's like dull aching or burning pain?
Yes, doctor. Maybe sometimes burning, sometimes dull aching. Yes.
Okay. Do you feel this pain is moving to any part of your body, like to your back?
No. No, doctor.
Okay. Do you have any feeling sick or getting sick?
No.
Do you have acid brush?
Yes, doctor. Sometimes, yes.
Okay. Do you have any difficulty of swallowing?
No.
Okay. Do you have any change in your bowel motion, like loose motion or hard motion?
No, doctor. No.
Okay. Did you notice any change in your water work, like increase amount or decrease amount?
No.
Did you notice any froth in the urine?
No.
Any change in the color of the urine? If that will work, sorry.
No.
Okay. Mr. Sami, do you have any history of long-standing disease I should be aware?
Yes, doctor. A lot.
Tell
I
me.
have, yes, doctor, I have increased blood temperature, increased blood pressure. I take 2 drugs for that. And also I have increased blood sugar. And also I take medication. And the doctor last time tell me he will escalate the drugs to insulin. And also I have high cholesterol because my bad habits in my diet. So I take also atorvastatin for that.
Yeah, for the blood pressure, since when you are diagnosed with high blood pressure?
Yes, doctor, I don't know since 5 years.
And what medication are taking now?
Yes, doctor, I take lisinopril. And
Yes.
yes,
What is the
lisinopril.
dose, you know?
I don't know, doctor, but it is
Okay.
high dose.
What else? What else?
I don't know. I don't know, doctor. Second drug.
Okay. Your blood pressure is controlled or
Sometimes,
or
doctor.
not?
Yes, sometimes. Sometimes
And are you taking
control.
your medication regularly?
I try. I try to take medication
Sometimes
regularly.
you're skipping the doses.
Sometimes, doctor. Yes.
And for the blood sugar, what medication you're using?
I take oral medication. But the doctor last time told me he will change it, will escalate it to insulin. But I still thinking about that.
Okay. And what about the control? Do you know the blood test that is being done every 3 months for the blood sugar control? Do you know the result?
I think, doctor, between 7 and 8.
Okay. And do you take it for the cholesterol
I try, doctor, to
medication?
take it. Yes, I try to take it regularly.
Yeah. And for the high cholesterol, you take what medicine?
I take atorvastatin 40.
Okay. Okay. Mr. Sami, do you smoke?
Yes, doctor, I smoke.
How many cigarettes for how long?
Yes, doctor, 20 cigarettes per day.
Okay, Mr. Sam. Mr. Sam, I advise you strongly to stop smoking. Smoking is not good for your health and also for your condition. So if you need any help regarding this, we can refer you to smoking cessation clinic.
Thank you, doctor. I will try.
Okay. Do you drink alcohol?
Sometimes, doctor.
Yeah. Do you know how many units per week or?
Yes, I think 10 units per week.
Okay. Mr. Sami, do you have any family history of heart disease or similar condition?
Yes, heart disease. Yes, my dad, my father has heart attack. Heart attack, yes, many times.
What was his age when he had this heart attack?
Yes, when he was 55, I think.
Okay. Any other family history of disease of note?
No, doctor.
Okay. Do you have any history of blood clot?
No, never, doctor.
Any family history of blood clot?
No.
Okay. Can I ask you what do you do for living?
Yes, I am not. I'm not do anything, doctor.
Okay, Mr. Sami. How much your symptoms affect your usual daily activities?
Yes, doctor, that affect me a lot. I have chest pain, and I can't tolerate it, doctor.
Yeah, I appreciate this, Mr. Sami. I hope we can help you regarding this condition.
Thank
Can I
you.
examine you?
Sure, doctor.
So I need firstly to check the observation chart
Yes,
for the patient.
yes, blood pressure 140 over 90, and the pulse around 90.
90. Okay. I need to check the hand. Okay, for any clubbing.
Okay, no clubbing, doctor.
Okay. Any pulmonary edema?
Yes, pulmonary edema, no.
Okay, then okay, I will check the pulse. Okay,
Pulse,
is it
yes.
regular?
Yes, doctor, it is regular.
Okay, then okay, I will check the eye for any pallor.
No valor.
Okay, I need to check the mouse for cyanosis.
Yes, no cyanosis.
Okay, then I need to do a cardiac examination. Okay, I will do palpation for the apex to check if it's in place or displaced.
Yes, the apex not displaced.
Okay, then I will palpate for palpable thrill in the
Where?
apex, left parasternal, and the pulmonary and the aortic area.
Yes, it is no thrill.
Okay, then I will check for left parasternal heave.
No parasternal heave.
Okay, then I will put stethoscope at the mitral area to check
Yes.
for any change in the heart sound character or murmur
Yes, no murmur, doctor.
or SS3 gallop.
No gallop.
Okay, I will check also the left parasternal and pulmonary and aortic area.
It's normal.
Okay, then I will check the back of the chest for the crackles.
Yes, no crackles, doctor.
Okay, then I will do fast abdominal examination with superficial palpation for tenderness.
Tenderness where? Sorry.
So for tenderness, he is telling there is abdominal pain. There is no pain.
Yes. No, doctor. This no. Can
No
palpate.
tenderness.
Yes. Can
Okay,
palpate.
then I will check the leg. Okay, for leg swelling
Okay. Normal.
and also peripheral pulsations.
Yes. Okay. Normal.
Mr. Sami, do you have any pain in the back of your legs, like cramp pain when you are walking?
No, doctor.
Okay, any pins or needles in your hand or feet?
No.
Okay. Okay, Mr. Sami. Can I know what's your concern, Mr. Sami?
Yes, doctor. It is heart attack like my father.
I appreciate your concern. Actually, heart attack is one of possibilities for your condition. The other possibility may be related to your upper tummy pain, and the acid rush may be causing some problem in your food pipe. But we should firstly exclude the heart attack. So we need to do heart tracing, and we need to do some blood tests to confirm our diagnosis. Then we'll discuss with you the further management plan.
2 minutes left.
Do
Do you have any other concern?
Yes, doctor. Do you will admit me in the hospital?
Actually, Mr. Sami, we will admit you to the hospital. Okay. As I mentioned to you, the heart attack is high possibility in your condition, so we need to confirm or exclude it. We will involve a group of specialists, including the heart doctor, okay, and the specialized nurse, and also the dietitian, and also the diabetes doctor, okay, to help you and to give you the proper management plan. Do you have any other concern?
No, doctor. Thank you very much.
Mr. Sami, sorry, do you drive?
Yes, doctor. I drive.
Actually, Mr. Sami, in the time being, you have to stop driving, okay, until we confirm our diagnosis. If it is heart attack, it's according to the management that we will give you, then we will come back to you to give you the proper advice about driving. Is that okay?
Okay, doctor.
Do you have another concern?
No, doctor. Just it is serious condition, doctor.
I'm sorry, Mr. Sami, to inform you that it can be serious if not treated early. And also we need to control your blood pressure and also the blood sugar and also the high cholesterol, okay, to help also prevent this from happening again. Is that okay?
Thanks, Dr. Ale. Thanks.
Thank you.
Okay, time is up. Questions?
Okay, please present to me your case and
Yes.
give and give me your diagnosis.
So today This gentleman is 45 years old. He has past history of hypertension and diabetes and this lipidemia. He is complaining of chest pain since 3 days duration, and he has also history of recurrent chest pain before. His chest pain character, he is telling like maybe heavy or burning pain, but no specific radiation. And he has also history of epigastric pain with acid brush. And he is also, there is history of heavy smoking and sedentary lifestyle. And he has family history also of ischemic heart disease. So my first differential diagnosis will be acute coronary syndrome. On examination, I couldn't appreciate any positive findings. So my first differential will be acute coronary syndrome.
Okay, any other diagnosis?
My second differential can be gastroesophageal reflux disease with reflux esophagitis. My third differential can be pericarditis, although the nature of the pain is not sharp pain. My third differential can be also pleurisy, although there is no other findings of chest symptoms.
Okay, doctor. Any other? Any else? What else?
The other can be like musculoskeletal pain, like costochondritis or myositis.
Okay, doctor. Okay, so what is your first differential diagnosis?
My first differential diagnosis, acute coronary syndrome, that's first priority to exclude.
Okay, what is in the history tell you that it is acute coronary syndrome?
The patient has multiple risk factors like diabetes and hypertension and dyslipidemia, and he has sedentary lifestyle, and he is not also compliant in his medications for it's not controlled, his diabetes and hypertension, and he has also family history positive for ischemic heart disease, and also he's smoking.
Okay, doctor. What's your opinion about this chest pain? It is typical chest pain or atypical chest pain?
Actually, from the history, it didn't give me a true symptoms of the typical cardiac chest pain. Also, it didn't give me other findings of non-cardiac pain like sharp pain or tenderness.
Okay, doctor.
Okay.
What increases chest pain and what decreases chest pain according to the patient?
Yeah, I didn't ask it. Yeah.
Okay, Dr. Ala. Okay, what will you do to this patient?
So this patient, we will admit him. Okay, we need to do for him. The first thing we'll do ECG for him. Okay, to confirm if there is findings of acute coronary syndrome. If there is like ST elevation, myocardial infarction, or other ischemic findings. Then based on the ECG finding, then also we'll do cardiac biomarkers. Then based on this, we will do the first line management. We need to do also basic blood test for him, and we need to do the hemoglobin A1C, and also check his blood glucose, and we need to check the lipid profile, and we need to do also urine albumin creatinine ratio, check the complication of the diabetes, and we need to do for him fundoscopy also to check for diabetic retinopathy.
Okay, doctor. You tell the patient you will admit him. So why patient need admission?
This patient maybe has acute coronary syndrome, so we need to confirm him this with serial cardiac biomarker. If they are negative and also the ECG, there is no specific findings, maybe after this we can discharge him. So we can just admit him to the ambulatory care unit or the short stay unit to
Yes,
confirm
doctor.
the diagnosis.
Okay. In this patient, this chest pain increased by eating. And what do you think about he need to do upper endoscope? Upper GI endoscope?
Actually, if there is alarming symptoms like blood in the stool or hemoglobin drop, anemia, or loss of weight, we can do upper GI endoscopy. If there is no alarming symptoms, we can just start medical treatment for him.
So, Dr. Ala, what do you think about this patient? You will do to if this patient is jailed. So, do you think you will do upper endoscope?
If he has alarming symptoms like loss of weight or
Okay. Is he had?
blood stool,
Mhm.
he has loss of weight,
No,
blood in the stool, loss of weight, or anemia.
no, Dr. Ala. Okay, okay.
Yeah.
You did very well, Dr. Ala. Really, you did very well. Apart from, sorry, Dr. Basim, I can
Right.
comment.
Yes, go
Dr.
ahead.
Basim? Okay, apart, Dr. Ala, you did very well, really very well. But if you ask me, what do you think? Do you think increase this chest pain? I will tell you that yes, Dr. It's increase with after the food, after taking food. And what do you think is this chest pain is increased by exertion? I will tell you no, doctor. I can go anywhere, no problem. So it is not chest pain. It is not typical chest pain. That's number one. Number two, the patient have many risk factors, high blood sugar, high blood pressure, and high cholesterol. So it is also high risk of this acute coronary syndrome. So this case is a case of differential diagnosis. No diagnosis in this patient. So first differential diagnosis will be GERD. And if the examiner tell you what is your the first differential diagnosis, is a GERD, typical GERD. But due to the patient have many risk factors, so I have to exclude acute coronary syndrome by doing cardiac enzymes, ECG and cardiac enzymes. Okay, so the first diagnosis will be first GERD, second acute coronary syndrome, or stable angina or unstable angina. Third, maybe peptic ulcer. Number four, it will be like DKA, but apart from that, there is no polyuria. You asked already about polyuria. But this patient may be polyuria, sorry, maybe DKA, because the patient tell you, I have the doctor need to escalate my medication of diabetes. So might be DKA. That is my differential diagnosis. So the patient tell you no need for admission. You will give him some proton pump inhibitor and then doing cardiac enzymes and ECG to exclude any cardiac event like MI or stable angina or unstable angina, and then discharge the patient and follow up with gastroenterologist. Okay. And the second, actually, Dr. Ala, this was concerned about the patient. I need to ask, doctor, if I need the upper GI. So you should ask in the history about any loose weight, any melena, like bleeding from back passage, or any difficult to swallow. This is the warning signs. So I will tell the patient, so do you not have any loose weight or any bleeding from back passage, so you don't need any upper endoscope. But you did well, Dr. Ala. Thank you very much.
Okay, thank you, Dr. Mahmoud. Nice case as usual. But I agree, Dr. Ala deserve good mark. He put
Yes, sure.
Yes, he put the coronary syndrome on the top of his differential to roll it out and to do some ECG to confirm the diagnosis. But we can say it's not acute coronary syndrome, it could be chronic coronary syndrome, right?
Yes.
Because the duration how much?
3 months.
So
3 weeks. 3 days, sorry, 3 days, 3 days.
If 3 days, acute coronary syndrome. But if more than this or 1 week, we can say chronic coronary syndrome. Anyway, he should roll it out by the ECG along with the cardiac enzymes, troponin and BNP. Okay. The other comment about the package question, you didn't ask about the loss of weight, which is very important to put in your differential something serious.
Because I asked him about the weight, he told me I am overweight. So I asked him, you gained weight? He told me, no, I didn't gain weight. So I thought the weight
Yes,
only, it's like
yes, sorry,
overweight.
doctor. Yes, sorry, Dr. Basim, but the cause of GERD in this patient is overweight. Is
Okay.
first by overweight.
Yeah. So you can say any change of the weights. Did you ask this question, Dr. Ana, in this way?
Oh, because he told me at the start that I am overweight, so I thought he is gaining weight. So I asked him, you gained weight? No, I didn't ask change weight.
Yeah, try to ask as a change, any change of the weight.
Mhm.
Don't ask
Yeah.
specifically any gain or loss. Any change of the weight, because sometimes it could be increase or gain, and other times it could be losing weight. So you will be asking as both question in one question instead of asking every question separately. Okay, and the appetite as well. But very important here, you ask about the scale of the pain. It's very important question. Why it's important to ask about the scale of the pain, Dr. Ala?
I think like to differentiate between the causes of chest pain.
Not only the
Uh,
cause. Yes, it's one of them, the causes, and it can
yeah,
give you a clue. But even
yeah,
for the admission, if
yeah,
this patient is having severe pain, 6 and above, you could admit him, and you have rationale about the decision of admission. So you can say he has severe pain or he has pain of high severity of a scale 10 or 6 or above, or whatever the pain is presenting. You have to say, this is one of the indication to admit my patient. Okay. The typical
okay,
chest pain, as Dr. Mahmoud said, the nature of the chest pain, the severity of the chest pain, the radiation, and the position or the place or the
Yes.
site.
Increased by exertion and decreased by the rest.
Exactly. So you have to ask all these questions as an analysis, particularly with chest pain. Okay. The radiation is very important. I think you asked about the back. Is it radiated to the back? Just to rule out aortic dissection, right? It was one of the differential if you have severe chest pain. Particularly the position will be in the middle of the chest and radiating to the back. But in our case today, it's different. However, you have to ask all these questions whenever you have a pain or a complaint of pain. The scale, the timing, the site, the radiation, what increase, what decrease, and onset course duration. It's little bit a wide question from any complaint else. Okay? Please write it in your note. Whenever you have pain, you have to ask all these questions. Onset course duration, of course, this is for any complaint. Particularly for the pain, you have to ask these questions. What increase, what decrease, any specific timing, and the site itself, and the radiation, finally, the scale of the pain. All these questions you have to ask whenever you have a pain in the complaint. Then, according to the nature, the nature as well. The nature will give you a clue about the case. Is it heaviness? So typical chest pain is considered as whenever the patient is have heaviness or heaving feeling, something is compressing his chest. Typically, you can say this is a typical chest pain, and you should rule out acute cold syndrome. Otherwise, it's going more with the GI symptoms and upper part of the chest or of the tummy. It's more with difficult swallowing, I hear, right? And there is also a change of is it related to the food or the meals? So the pain going more with GERD. However, since this patient is having very high risk, you have to rule out ischemic heart disease or coronary heart disease. Why? He's heavy smoker, family history, diabetic patient. And by the way, diabetic patient might have chest pain or non-typical chest pain or atypical chest pain. The nature will be changed because of the diabetes. Even sometimes he will not have a pain, as we know, accordingly, due to the diabetes and according to his controlled. In this scenario, I'm not sure he's controlled or no. It was
Not
high,
controlled.
not
Yeah,
controlled.
yeah.
So definitely you have to put ACS or acute coronary syndrome, one of the differential. Okay. Any question else? Dr. Mahmoud and Dr. Ala?
Thanks, Dr.
As,
Nasser.
as a case, the case is a case of differential. So we don't have, but you have to put ACS, and we talk about ACS, how to do and how to analyze. Admission, of course, you have to admit. Yes.
The admission for this patient.
You said good sentence. I will admit him to do the tracing, or I will do ACG and rule out ischemic heart disease or acute coronary syndrome. After that, he might be referred to the outpatient clinic. For me, this is the perfect answer. You cannot do more than this. After ruling out acute coronary syndrome by doing ECG and serial troponin, you can say 2 sets of troponin. Okay, don't say only one. But if there is a typical chest pain, it's okay. But if there is possibility, you have to do 2 sets. So you repeat troponin twice. After that, the patient might have discharge, and you can give him appointment in whatever the clinic. Is it upper GI? So you refer him to the gastro, either to proceed for endoscopy or no. They will do image, barium swallow, whatever the condition. Even chest X-ray can give him a clue or can give us a clue, but he will not be admitted as inpatient. This is my opinion. I think Dr. Mahmoud also can confirm.
Yes, Dr. Nasser, that is the answer, really.
Yeah.
I will
Okay.
do, yes, some heart tracing and cardiac enzymes to exclude MI, and then if it is no MI, I will refer him to the gastroenterology clinic.
Perfect.
Mhm.
Okay. The other point, the driving issue, you raise it at the end. I don't know why you link it with the case here because of the chest pain, but you don't have confirmation. Will you stop him from
Yeah,
driving? Is it
yeah. If it's
important to ask and to advise? This is my point. Or to wait
yeah,
until it would be positive.
yeah, but that's what I mentioned to him that until we confirm the diagnosis, then we'll come back to you to give you the proper advice.
Okay, but you can
Because if
list it.
it's like MI, I think he needs to stop driving.
Okay, I'm not sure, but it's not going with MI. You admit him to rule out MI, but your answer will be it's not or it's unlikely to be MI. By the way, this is the answer of the concern. He asked you, doctor, do I have heart attack right now? So where is your clinical judgment? Yes, I want to rule it out, but do you think it is heart attack by the nature, by the radiation, by the scale?
After what Dr. Mahmoud said, I can't change the answer.
Okay. Yeah,
I would say the heart attack is a possibility, but mostly you have a condition which is
exactly.
called yes,
Yeah,
yeah,
unlikely to be a heart attack.
oh possibility.
Yeah, the possibility more to toward, for example, the GERD or something in your food pipe, difficult of swallowing. Since you have acid brush and feeling of tasty feeling in your mouth, so it could be, but we have to rule out the acute coronary syndrome. Okay, or the heart attack. Sorry, you are talking to now to the patient. So we want to rule out the heart attack by heart tracing. After that, we will confirm the diagnosis by doing our other investigations. This is the answer. I think it would be the perfect, since the relation to the meal and the food, and along with the difficulty of swallowing. Right, Dr. Mahmoud? You want to add any comment?
I can't eat after you, Dr. Bassem.
No,
Never.
it's your case. You
No,
are the
no,
one
Dr.
prepared
Bassem.
the case. I just comment on the performance, but about the case, it's now going forward to the gastric or esophagitis, right?
Yes,
Yeah,
Dr. Bassem.
yeah, a good comment. It was from, I think, Dr. Henry. He wrote, is it related to the medication? What do you think, Dr. Ala? Any of these medication or his medication can cause difficult swallowing or dysphagia or chest pain? What do you think?
But he doesn't have difficult swallowing. I asked him. He doesn't have difficulty swallowing. The
Okay,
he give yeah
feeling
he give
of
me
acid
he give
brush.
yeah he give me the medication, but he didn't give me the medication for the diabetes.
Okay.
Maybe if it's taking metformin for diabetes, it can cause like this.
Yes. So whenever you have medication in your case, ask him about the medication list. Show me your medication list and try to pick up one. It might be there, one or two of the medication which might be the cause of his symptom. For example, I will give you example in this scenario. Could be, but indirect way, but it could be. Okay. What about statins? Statins, myositis, chest pain. Do you think it could be related? Even indirect way, as I said. And by the way, it could be a concern from the patient. Doctor, do you think it might be the case, by the way, in the exam? Right? So
Yeah.
always think about the medication as side effects. This is the lesson from my talk. I am not saying it as the case. No, I'm talking as a take-home message. Whenever you have polypharmacy, 5 medication or more, you have to think about drug or drug-induced or medication side effect. In this scenario, myositis, if there is atypical chest pain related to the muscle, for example, myositis, and the patient is feeling fatigue, he cannot, yeah, and he has paroxysmal with the other muscle pain, you can think about myositis. I give it as one of the medication in the medication list, but it's not the case. Okay, let's imagine another medication can cause or lead to chest pain related to the diabetes and hypertension. Anyone knows? Okay, if this patient is taking PPI, do you think you can add differential?
PPI.
Yes. Omeprazole, for example, pantoprazole.
Yeah.
Is it possible to be esophagitis?
I don't know, but PPI is supposed to one of the
Yes,
treatment
it
for
could
esophagitis.
be. Yes, it could be the treatment, but as xenophilic esophagitis,
Yeah, I think I can.
right? It's not common, but we have to think about it, right? What else? Yeah, if this patient, for example, is having osteoporosis, he or she is on bisphosphonate, as we mentioned in the previous scenario, it could be the reason of his or her dysphagia, and the pain will be in the chest, esophagitis, right?
Yes, Dr. Bassem.
We are trying to search for the other causes, but it's not the case. Our case was straightforward to GERD related to the. It's not related to the medication, maybe related to the multi or comorbidity the patient is having. But the good thing, the examination was perfect, Dr. Ala. You examined the heart properly to rule out any murmur because it's very important. It might be there since he's having all this comorbidity and hypertension as well. He might have also any change in the heart due to or related to the hypertension. Okay. Any question, Dr. Ala or Dr. Mahmoud?
Thank you, Dr. Bassem.
Thanks, Dr. Bassem. Thank you.
Most welcome. Let's go quickly to the comments. Dr. Henry, I think he puts the perfect differential. drug-induced dysphagia or dyspepsia. Okay, dyspepsia. GERD, pancreatitis, angina. Okay, in the paces wise, Dr. Henry, you have to put angina on the top. Okay, just roll out them, just roll out it, but you have to put it earlier, not at the last one. It's not CS in this case, but you have to put it earlier in your list. So you might put it after GERD, and the GERD will be the number 1. GERD may be due to medication, okay. Esophageal reflux, okay, Dr. Ayula, yes. Cardiac causes, chest causes, GIT causes, Dr. Adam. Again, it's the layers of the chest from outside inward. So you can start by the skin, the muscle, the joint, the lungs, pleura, pericardium, cardiac, and even the cardiac, myocardiac, endocarditis, or pericarditis. Okay, ACS-PE, Dr. Ayula, this is initial, I think. ACS-PE, mechanical, ACS pneumothorax PE. Yeah, this is as initial possible cause in paces, and this is the most common. You have to put them from outside. PE, MI, pneumothorax. These are the most common cases in paces. Add to them pleurisy.
pulmonary embolism.
Pulmonary embolism and pleurisy. Yes, pulmonary embolism mentioned PE. So you have to put pleurisy as a SLE, commonly coming in paces. SLE and other autoimmune. Okay. So try to put it in your paper from outside. Then, according to your history, you reach which one will be appropriate as a differential. Okay. Yes. For the first scenario, sorry, because I said wrongly, and Dr. Buckingham corrected me. The cancer, esophagus or esophageal cancer, the difficult swallowing it will be initially to the solid, then later on will be even to the liquid. One also more comment, the achalasia will be to the solid and the liquid simultaneously at the same time from the start. Okay. Any question or suggestion or comment? Anyone want to say anything? Any question? Any suggestion? We'll end the session. Thank you, Dr. Mahmoud and Dr. Ala. Thank you for the attendance and the candidate who wrote the differential. We'll see you inshallah tomorrow with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.